Now I am putting some scenarios to quickly understand and revise these levels. Number 1, patient is gravida 3 para 2 at gestational amenorrhea of 32 weeks with history of headache for 1 day and liquor per vaginum for last 4 hours. Her pulse is 90 per minute, blood pressure is 140 by 95 and fetal heart sounds are 132 per minute and she is having no palpable uterine contractions. Now, what is her level? She comes under the priority 2 level. So, she should be seen in 15 minutes. Next patient is Rubina. She is primary gravida having gestational amenorrhea of 36 weeks and 3 days with severe pain abdomen but having no palpable uterine contractions on examination. And her pulse is 92 per minute, blood pressure is 140 by 80 and the fetal heart sounds are 136 per minute. Now, what is her level? She also comes in the priority 2 and she should be seen within 15 minutes. Next is Sugram. She is para 4 with no miscarriage and came with the history of delivery at some periphery 4 hours back. She presented with heavy bleeding per vaginum for last 2 hours. Her vitals are pulse 128 per minute, blood pressure 90 over 70 millimeter of mercury, respiratory rate is 26 per minute and she is drowsy. Now she is having priority 1 level or the stat level and she should be immediately addressed and given attention. Next patient is Zahida. She is gravida 3 para 2 having gestational amenorrhea of 38 weeks with history of previous 2 cesarean sections. Her vitals are pulse 89 per minute, blood pressure is 120 over 70 millimeter of mercury, fetal heart sounds are 136 per minute and she is not having any palpable uterine contractions. Now what level she is having? She is having priority 5 level, means that she is an elective patient and she should be seen within 120 minutes or 2 hours. Next patient is Bano Bibi. She is gravida 4 para 3 having gestational amenorrhea of 35 weeks and 3 days with twin pregnancy and leaking per vaginum for 4 hours. Her pulse is 90 per minute and she is having no palpable uterine contraction. Her blood pressure is 120 over 75. She is again having a priority 2 level and she should be addressed within 15 minutes. And the next is Razia, gravida 2 para 1 having gestational amenorrhea of 34 weeks and 2 days with pain abdomen. On examination, she is having palpable uterine contractions and her Bishop score shows that cervix is 4 cm dilated, 50% effaced and the station is high up, membranes are intact. Her vitals are pulse is 90 per minute, blood pressure is 110 over 70 millimeter of mercury and the fetal heart sounds are 131 per minute. Now what is her priority level? She is having priority 3 level, means that she should be addressed within half an hour. What are the recommendations? Obstetric triage volume exceeds the overall birth volume by 20 to 50% of the hospital. And the hospital-based obstetric units are urged to collaborate with emergency department and hospital ancillary services as well as emergency response system outside the hospital to establish guidelines for the triage of the pregnant females. Now, recently developed validated obstetric triage equity tools may improve quality and efficiency of the care and guide resource use, and they should serve as a template for use in the individual hospital obstetric settings. Now, what is note? MFTI is exemplary and it does not include all possible patient complaints or the conditions. It is designed to guide clinical decision making but does not replace clinical judgment values and appropriate for the population and for the area. Should be determined by each clinical team taking into account the variables like altitude, etc. Now, I hope you would have some idea that what triage means and you will try to apply at your respective obstetric units. Thank you very much.